Hello, everyone, and welcome to today's webinar, Torch Infections, Screening versus Diagnosis. I am Marie Stone of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Abbott. To learn more, visit corelaboratory.abbott.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. I'd like to now welcome our speaker, Dr. Claudio Galli, MD, PhD, Associate Medical Director, Infectious Diseases, Core Diagnostic at Abbott. Dr. Galli, you may now begin your presentation.
Hello, everybody. Thank you for joining today. We are discussing today serology, serological testing for screening and diagnosis with a focus on congenital infection. First of all, disclaimer, of course, I'm speaking on behalf of Abbott. I'm working for Abbott. And now let's start with some definition. When we deal with screening and diagnosis, actually, those are a different ballgame. So you see the features here, the purpose of doing that, the target population, test method, the threshold, the positive result evaluation, and the cost. So when we are dealing on screening, we are pretending or hoping to detect potential disease indicators in individuals that are mostly or all asymptomatic, potentially at risk. The method we choose should be simple, acceptable, and of course to the people and the staff that will perform testing. The positive result threshold is set in a way to maximize sensitivity because we cannot afford to miss potential disease. And the positive result brings a suspicion of disease and needs confirmation. Ideally, a screening cost should be cheap. The benefit should balance costs due to a high number of individuals to be screened. Whereas when we go to the diagnostic side, in that case, we need to establish to diagnose the presence or absence of any given disease. So the population will be mostly symptomatic or should have been positive by the screening and then needs confirmation. The test method may also be invasive and complex because this is justified by the need to diagnose, and the main characteristic should be specificity, so having true negatives, and there is a major weight on accuracy. The positive results should confirm a suspect diagnosis, always in association with clinical data. So no assay will provide the diagnosis by itself. And it could also be more expensive, and this is again justifiable by the need to establish a diagnosis. Now, let's take a few questions during this webinar. I hope this will be appreciated by you. First of all, when you have laboratory assays available for screening and diagnosis, are those different according to the purpose of testing? Are those the same ones with diagnostic thresholds that are adapted according to the clinical need, or are the same ones, mostly the same ones? And what makes a difference is the combination and sequence of assays to be used and interpretation. And the right answer is the last one. Very often, if not every time, we have the same assays available. And I would say that what makes a difference is really the combination and sequence of results of the assays and how you do interpret the criteria you use to interpret those. Let's start with a very common infection, which is the human cytomegalovirus infection. You know that cytomegalovirus is an herpes virus. It affects a variety of cell compartments from the ectodermal layer. And so it is also known as one of the most common and persistent infections we have as humankind. The very brief life cycle is described here. We will not waste your time on that. The relevant thing is that once the infection is established after the acute productive phase, there's this chronic latency phase that never ends. So it's for a lifetime. And during the course of a lifetime, there will be several chances for the infection to reactivate. As I said, this is a very common infection. So you see here some data on prevalence. Not all countries do report prevalence, so no data are very frequent, but you may also see that in the majority of countries, the prevalence of CMV infection ranges between 60 and more than 90%. So I would say that in an adult population, the vast majority of people already are infected. And this, of course, brings some consequences on the testing results and the interpretation of the testing results. When you are dealing with CMV testing during pregnancy, you have to consider that that period is all prone to infection. We don't know beforehand, most instances, I'm sorry, if the person has been infected before or not. So we do have the likelihood to screen, and usually many people will try and do screening during the first trimester of pregnancy. And in that case, you may find either an infectious syndrome with symptoms, or more often than not, just a serology that is suggestive on a CMV infection. The imaging may be valid, but only in the later phases of pregnancy, as you see here. And what is worrisome is that in most instances, screening is yet not performed, and in case an infection appears, then the consequences during childhood will appear. Let's try and define it a little bit better. So what happens is that there are two major possibilities. The first one, which is the rarest, is that during pregnancy, a primary infection occurs. In this case, the transmission rate is very high. Whereas if the pregnant woman has been already infected before, which is quite likely, by the way, being her usually an adult, then the reinfection or reactivation may lead to transmission in a percentage that ranges between 0.5 and 1%. It is not really certain because we don't have so many data about that. So regardless of the status of the mother, the majority of newborns will be asymptomatic at birth. Those that are symptomatic, that 10-15%, will have sequelae in 90% of cases. So this is the high risk we should try to prevent. Whereas in case of asymptomatic infection, unfortunately, you still have the development of sequelae, but this is much rarer. So it ranges between 5 and 10%. And you see here, which are the most common disorders, and the sensorineural hearing loss is usually the most common. We should remember that CMV infection after Down syndrome is the most common cause of congenital disease in the world. So this is something we should really look very careful at and try and prevent as much as possible. Now, what happens during the course of a CMV infection? What do we use? Well, this is exactly the case in which exactly the same assays are used both for screening and for diagnosis. And the flow, the appearance of the different biomarkers is depicted here. This is, of course, a generic scheme, not so precise, but to give you an idea, during a primary infection, you have an initial positivity for AGM, followed almost immediately by the detectability of IgG specific to CMV, and the avidity of antibodies towards CMV is rising during the first weeks or couple of months after the infection. Point is that when there is a reactivation, CMV IgG will already be there, the avidity should be high, and the IgM could be detected and usually are detected again. So as you see here, there is quite an inconvenience in the sense that IgM testing alone cannot predict really if the infection is a first infection, a primary infection, or a reactivation. But the point is that the IgM testing we use should be as sensitive as possible. And this is an example of why. This is quite an old paper, I would say, in which pregnant women were tested by different assays for IgM to CMV. And the other assays that have been done in these cases are the IgG avidity and the child vial testing for CMV shedding in the urines, which of course is an indication of the reactivation of the infection and then the likelihood to transmit again. As you see here, there are cases in which one assay may be positive and the other ones are not. And unfortunately, in some of those cases, you do see a low avidity and you may see CMV shedding. So In case the test comes up negative in those cases, you are missing infections that are indeed able to be transmitted to the fetus. So this is the reason to have an IgM testing that is as much sensitive as possible. But on the other hand, think about that. If you're looking for screening in a high prevalence setting, as most countries, especially in the Western or Central Hemisphere, will be, which will be the positive predictive value of a CMV IgM test? Would it be very high? That is, IgM positivity almost always linked to acute or recent infection, will be fairly high, or would it be low, as almost all people have a chronic infection and IgM positivity is mostly linked to reactivation? And the right answer is the third one again. And we have data on that that are pretty, I would say, interesting to look at. This is an observational testing carried out in Canada last year, published last year. Without focusing on all the flow here, just look here on the right. When CMV avidity, IgG avidity, has been performed on samples that were positive for IgG and IgM, that were 113, well, only 4 of those had a low avidity. That is, only 4 of those samples were taken from pregnant women with an acute primary infection. All the other ones were old infections, chronic infections that did reactivate during pregnancy. And the rate of reactivation during pregnancy is fairly high, may reach out 20% during the whole course of pregnancy. So, of course, this is, again, a very good reason, practical reason to not to limit testing to IgM and IgG, but to carry on IgG avidity. And this is the schematic flow, if you wish, on how screening should be done or is currently done during pregnancy. So you start with both IgG and IgM. If both negative, there is still a counseling to be done in order to avoid behaviors that may lead to a primary infection during pregnancy. So counseling is very appropriate in this case. If during that period you have a seroconversion, then in that case, without any need of further testing, this is a primary infection. And the need for a prenatal diagnosis is really huge. The other instance is that you may have a positive serology, either for IgG alone or for IgG and IgM, in rare cases, IgM alone. In that case, IgG avidity should be performed. And again, if it's low, as we have seen in the example before, and the confirmation for IgM is then done by this avidity testing, then there is a primary infection. We revert to that status. On the other cases, if the avidity is high, this is definitely a prior infection, so no further testing is recommended. A gray zone that may happen because all CMV IgG avidity assays do have a gray zone, so neither positive nor negative, that in that instance there should be counseling and retesting as soon as possible within a couple of weeks to try and sort out if the infection is recent or not. Then the utility is depicted here. If you wish, this is a repetition just to confirm. You start with exactly the same generic picture of a positive IgG and IgM. In the first case, patient 1, this is a primary infection with a low avidity. In the second case, which is much more common, you will have a high CMV IgG avidity, and this is a reactivation. Point is that even the best assays are not perfect. So this is where the clinical picture does play a role. This is not exactly the case in pregnancy, but if you look at special groups, such as in this instance, immune-suppressed patients after transplantation, you may find a low CMV IgG avidity also on samples that are belonging to a chronic infection. And this is why knowing which is the status of the patient before performing testing is absolutely relevant. Again, no assay, no combination of assay will be absolutely diagnostic per se. We need to have the clinical criteria as well. And this is something that the lab should request, especially in the case of dubious results, in every instance. Another point is that if we look at the most recent recommendation, at least from the CDC, You see this phrase here. It is not recommended that doctors routinely test pregnant women for CMV because the laboratory test cannot predict which developing babies will become infected or have long-term health problems. Well, this, first of all, does not take in account the results of CMV IgG avidity that possibly is not so widespread. Second point, it assumes that once the infection is diagnosed, there is nothing to do except possibly termination of pregnancy, which is not the best possible outcome. And this, remember, is coming from a few years ago. What happened next is that nowadays we do have evidences that antiviral treatment during pregnancy is available, it's safe, and may prevent vertical transmission of CMV. You see here this outstanding paper published on Lancet 2 years ago. You see which are the differences, the yield in terms of reduction of the transmission when you use valacyclovir compared to placebo. This is still one of the cases in which placebo was considered. You know that in many instances there are ethical concerns about having this kind of studies, but the first instance when you have to prove drug safety and drug efficiency, you do that. You see how huge the difference is. And so this may lead eventually to a change in the CDC recommendation, and for sure it will lead to a change in CMV testing practice. So to conclude, you know by now, we already know, of course, but this is to clarify the issue, that we do have a clear picture of CMV serology, and we can't foresee a need for new biomarkers to be developed because the current combination of IgM, IgG, and reflex testing for IgG avidity in case of positivity for IgM and IgG will guarantee a good accuracy in the diagnosis of discrimination of recent versus chronic infection. So we are coupling the screening first and the diagnosis later. And CMV screening is still controversial, but we now have the availability of a treatment that for force will lead to a wider consensus for its implementation. And that was CMV, but of course there is not only CMV in this busy world. So let's take a look at a clinical case, common presentation. Let's read together. This is a 34-year-old male individual that since last week has fever, pharyngodynia, rash, swollen cervical lymph nodes, moderately enlarged and soft spleen, sweating, fatigue. The anamnesis reports frequent travels, high proximity with people the same age or younger. The presumed diagnosis is an acute infectious diseases, likely of viral origin, but the person was tested for CMV, for Epstein-Barr virus, and for toxo, with those results as you see here. Well, CMV IgM negative, so this is not an acute CMV infection. In this case, for EBV, you have even IgG positive. This is developed many weeks after the acute infection, so this excludes an acute EBV infection, even if the IgM are positive. Same story as for CMV. You have the IgM positivity that is prolonged, or during reactivation may appear again. And you have a positive result for toxo, IgG, and IgM. So you would presume, okay, this may be a primary acute tox infection. This may be. Okay? But, of course, serologically, it makes sense because even during an acute infection by Toxoplasma gondii, you have the positive IgG that then wanes down but may last up to until 1 year and will appear again during reactivation, same story as before. Then after a short lag of time, you have the development of IgG, and then again you have the avidity that was not used in that case because this was a different field, okay, a different ball game, as we said at the beginning. So it could be toxo, serologically, right? The point is that generally, a primary infection by Toxoplasma gondii is asymptomatic in immune-competent persons. This is a 34-year-old young male. It's symptomatic in 10 to 20% of cases, and commonly it has lymphadenopathy, which we did see in that case, fatigue, no fever, or very low temperature compared to what we've seen before, chorioretinitis that was absent, and the clinical course is benign and self-limited. So go back to the case we have seen before and just point out that in this case we had fever, pharyngodynia, which is not typical for toxo, the rash, and the sweating, and this frequent travel, site proximity. So the other tests that have been performed in this case were for HIV, and it came up as positive. So this is an acute infection by human immunodeficiency virus, and this was the final diagnosis. Again, once again, you combine the results that you obtain by microbiology, virology testing with the clinical evidences, and you end up with a defined diagnosis. I hope this is something that is pretty much clear, and I'm sure that quite a few people here have seen such a picture at least sometimes. But let's go back to toxo. Well, toxoplasmosis is mainly transmitted not by cats, as, okay, this is a possible factor, but not so frequent, usually by undercooked or raw meat or contaminated water, fruits, and vegetables. But there is also the risk for a intrauterine transmission, and this is why we are dealing with that in the section devoted to congenital infections. And congenital infection that results from an acute primary infection, not from a chronic infection, has a different degree of severity according to when it occurs. In CMV infection, it is definitely worse to have the infection early during pregnancy. So the earlier, the worse. In this case, the incidence and severity increase by trimester, so it's highest in the third trimester. And it may be, again, symptomatic or asymptomatic, as we have seen before. This is the classic triad of the congenital, toxo, hydrocephalus, chorioretinitis, and intracranial calcification. You may have also other consequences, but the good news here is that the treatment is established since years. So there is a definite chance to treat mothers, future mothers that are infected during pregnancy in order to reduce the incidence of congenital infection and its sequelae. Just to mention, this is a classical paper on toxo by two outstanding authors here, and this is the approach for treatment in women that are suspected or confirmed to have acquired toxoplasmosis during gestation. According to the weeks, there are two different kinds of treatment recommended. Both are safe, have a good efficiency. There is also the likelihood or the possibility to switch from one treatment to the other if the first one is not effective. Of course, you need to monitor the fetus during the treatment and eventually also to carry on further diagnosis at birth. So this is completely different from CMV. There is an established path since years, and nobody is questioning about the need to screen for toxo during pregnancy. And serology for toxo is apparently easy, if you wish, the same combination IgG, IgM, but we have to deal with something that is not so easy to interpret. It is mainly related to the IgG detection. A very recent statement from French authors, and France is very advanced in the diagnosis, in the screening and diagnosis for this infection, stated that the first line criteria for IgG should need a maximum specificity along with detection sensitivity for low or equivocal titers in both chronic and recent toxoplasmosis cases. So this is one of the cases in which we want to have everything. Good sensitivity, maximum specificity. We may achieve that. Most assays are very good. Just to make an example, this is a comparison by the same authors in which you see that actually in terms of sensitivity, all assays considered are good or very good, and even better as far as specificity is concerned. So apparently, we don't have an issue, do we? The point is that when you start confronting the assays, there are quite a few inconveniences. Same paper brings up those examples. So the 9 toxo IgG assays that have been compared were confronted with samples with a range of IgG levels that are low, medium high, or high. And you see that the absolute values generated by the different assays are completely different. So when you deal with low values, the ones that were pinpointed 2 slides ago, which values are we talking about? Low values by which method? And this is the issue. We don't have a real balance, a real concordance in quantitative levels across toxo IgG. And this is a couple of examples from another study. You see that the same assay on the X assays is from Diasorin. Two different assays from other manufacturers show an overall correlation, which brings up nothing because, of course, since the assays are detecting the same analyte, they correlate. But the point is that the results are completely different. Underestimated in this case, overestimated in that case. Why is this happening? Well, this is the general problem of quantitation for antibody assays. Actually, we do not count antibodies. We are measuring antibody affinity and avidity, and potentially also different classes. So it is not unexpected that assays will display sometimes a low correlation, but very often slopes that are completely outside of a decent range. And the literature indicates significant concentration differences, as we have seen, between methods. Which are the reasons here? Several. First of all, which antigens are used to detect the antibodies? Then the assay format, direct, indirect. Then the technology that will bring a different dynamic range. And last but not least, the standardization. We would say, okay, we do have a toxo standard. Point is that we had several toxo standards over the year, and as you see here, the different assays that are employed, these are 4 out of the 9 we have seen before, do have a different interpretation, different antigens, different WHO standard. You see that the 3 of them are depicted here. This is the newest, this is the oldest, this is the so-called third standard, which, by the way, was quite a mess because it was made of a pool having together IgG and IgM. And quite logically, the range is different and the interpretation of results is different, completely different. So what you may do, or what has been done in several experiments, is just try and normalize the IgG results by recalibrating towards the most recent international preparation, which is the first toxo, and is purely IgG. So there is no confusion having IgG and IgM together, as we have seen in the former standard. This is what would happen. You see that assay that has been already calibrated towards the newest standard stays the same with very good coefficient of variation. Those assays that initially did bring much higher results because the standards and the technology and the antigens were different are down to a level that is indeed acceptable. You see that the differences here are very small. Unfortunately, in clinical practice, we cannot re-standardize assays. So we have to keep using the same assay over time. This is definitely a field in which, first of all, you cannot afford to change assays during monitoring if you have to monitor. And second, you cannot pretend to convert results from one assay to another one. There is no correction factor. This applies to every antibody, quantitative antibody assay, is especially true for toxo. And even in this case, going back to the simplest thing, which should be the IgM reactivity, we have the same issue about predictivity we did encounter with CMV. The difference here is that toxoplasmosis is not so prevalent as an infection as CMV is. So the predictive value is higher, but it is not 100%. This is a real-life observation from my country, from Italy. They took 3 years of routine. This, in dark blue, is the incidence, okay? So, which was the actual incidence of toxo infection in the screening population. And this is the predictive value for an acute infection of the IgM reactivity. So best case, it was 86%. Worst case, barely above 50%. So once again, you cannot rely just on IgM positivity to diagnose or exclude a recent infection. And we should remember the or exclude. Why? Because in this case, what happens is that the avidity testing will allow to exclude, but not to include a recent infection. Well, first of all, another set of questions. The avidity testing results, are those different according to the assay used? Are usually in agreement on diagnosis of a recent infection? and not so much in agreement on excluding a recent infection, do not allow to diagnose a recent infection, are usually consistent on the purpose of excluding a recent infection, but without 100% agreement. Well, again, anticipated that. The assays cannot diagnose a recent infection. The assays may exclude a recent infection, which is completely different. And this is how they should be used. And even the best assays here are not 100% accurate, of course. Unfortunately, neither there is 100% agreement, but definitely there is a much better agreement for toxo-IgG avidity across assay than we do have for CMV, for the very simple reason that for toxo, first of all, there is a way more experience about testing, and second, we are using the assays just to exclude a recent infection, which is good, by the way. This is just to show a comparison across two assays. We are not interested really in the correlation. We do see that indeed the samples are classified according to a threshold of 4 months before or after. Again, we cannot diagnose the recent, but we can exclude the recent, which is what happens with all those dots here, and the accuracy is fairly good. And this is a detail about one of the assays here that by chance is the Abbott assay. You see what I mean here? When you have a high avidity, none of the sample assay that had been taken in the first 4 months after infection, which is absolutely fine because the risk, once again, the risk for fetal newborn disease is highest when infection is transmitted during the 3rd trimester. So if you have the ability to exclude what happened and may say that infection is there, but it occurred more than 4 months ago, this is safe enough and this is good enough. There are efforts to try and have toxo-IgG avidity also able to diagnose a recent infection, but there are quite a few inconveniences I will not detail about. Just to mention one, in case the infection is treated early after onset, which is something that is absolutely possible during pregnancies, as we have seen, then the serological response will not develop the same way as in untreated cases, and the maturation of avidity will be delayed. So you may have a low avidity even in infections that have occurred a lot of time before. Of course, you will say, you know that you have been administering treatment, but what if the person changes monitoring or changes places? This could be a confounder. We did forget rubella, didn't we? Well, indeed, there is something to say about rubella as well. This is, again, completely different compared to CMV and toxo, because in the case of rubella, we do have vaccination. We have vaccination since decades, and the rate of vaccination is quite high. We still have this residual risk of congenital rubella, and in this case, the risk is the opposite compared to what we have seen with toxo. So the risk of congenital rubella is inversely proportional to the period of gestation, highest in the first part of pregnancy, and then much lower after that. We don't have the large epidemics, but in some remote areas where there is a large part of the population that may be susceptible, we still may have some major epidemic. And unfortunately, even in countries that have been vaccinating against rubella since decades, the coverage may not be ideal, and we do have periodically small epidemics of rubella during pregnancy, which is really unfortunate because no treatment is there. So when testing for rubella IgG during pregnancy, this is something that is routinely performed. The options here are, you may change assays because the positive threshold is the same across methods. Or each assay is a different threshold and a different dynamic range, so assay results cannot be transferred from one method to the other. Or low positive results should be evaluated with care as there are evidences questioning a protective threshold. Or finally, any positive results shall guarantee immunity, so no risk of transmission. Well, the right ones, more than one, are those two. Each assay has a different threshold, but most are around 10 units per ml, but some of those are not at that level, but they have a different dynamic range, and the results cannot be transferred from one assay to another. This is exactly what happened also for toxo IgG. And this is the bad news, if you wish, a low positive should be evaluated with care. So if we go to the classical combination of results for rubella testing in pregnancy or in general, if you have a positive IgG and a negative IgM, the classical definition is this person is immune. So prior vaccination or natural infection, no further testing required. If IgM and IgG are negative, this is susceptible, so you should take care, again, counsel in order to avoid getting infected during pregnancy and repeat following a suspect exposure. If only IgM are positive, this could be an acute or a false positive. You have to sort out by a second sample. If both are positive, this is either acute or false positive IgM, and again, you may resolve the doubt. But the point is here, because in most instances, testing will yield a positive IgG. And there are questions about the immunity on any individual that is positive for IgG. And this is quite a long explanation. First of all, the standard. Well, the standard has changed over time. It was based, and it's still based originally, on hemagglutinin inhibition titers that were equal to 15 international units, then revised to 10 international units 20 years ago. But first of all, there is a gray zone to be considered. A gray zone could be relevant because no assay is 100% precise, absolutely no assay, especially in serology. So having a clear-cut threshold will bring inconveniences in case of results that are just above or below the threshold. And most of all, and this is very relevant, there have been evidences of reinfection in individuals with IgG titers or levels of more than 15 units. Then the assumption that the results of 10 always confer protection against infection or reinfection, and results below 10 indicate susceptibility to infection is not correct. And this is something to be considered very carefully, because when we have the borderline results, we should be very careful to state that the person is immune. It would be much safer if testing is performed as it should be even before pregnancy to recommend a further vaccine dose in order to avoid serious inconveniences but not having the person protected. And once again, as for toxo, the results obtained by different assays are very different. This is an external quality scheme. I guess that most of you do participate in those. You see how different the results may be. Without wasting your time any further, the reasons are exactly the same we have seen before. Standardization, antigen not so much because it's always a viral lysate, but the purification processes may be different. The assay format and the technology. So this is a conundrum. We cannot solve that by the moment. So even if assays were used and standardized against this preparation, the results will still be different, and we need to consider that. And this brought the Professor Dimek, which is really very good at evaluating serology, as many of you should know, to assert that indeed it would be way better to have qualitative assays for rubella instead of quantitative, because quantitative results need to be linear, forcing the reactivity of high negative to close to those of the positive, low positive. And as we've seen before, a low positive is not really indicative of protection. So this is something that maybe would happen in the future. Having quantitation not to such a high degree, because it's not really possible to have a perfect agreement across assay, but cooperate industries, manufacturers, and of course people that are taking care of the expert testing and bringing out the standards in order to have a clear-cut definition of rubella positivity that could be applied to everybody. Okay, this is basically what I was wishing to share with you. Just before the end, and just out of curiosity, this is a clinical case unpublished that a good friend of mine from Bologna referred a few years ago. Let's have a look together. So, this is a liver transplant patient treated with hepatitis B immunoglobulin, hyperimmunoglobulins to prevent HPV reinfection. Tested over time frequently after transplantation, as you see, you have this, that is the IgG to CMV, going down, positive at the beginning, going down, then up again. Avidity was very high at the beginning, then abruptly became very low. And IgM that was positive at the negative, sorry, at the beginning of the observation, then tested positive throughout the whole testing period here. So what is this? Well, believe it or not, this is a primary CMV infection. What about the IgG and the avidity? That's simple. In the preparation of hyperimmune globulins that were administered to prevent HPV reinfection, there were also CMV IgG antibodies. You remember that CMV is very common, so basically almost every adult will have also CMV IgG. So those are passive antibodies, and this is the active antibody response to the primary infection. Quite unfortunate. Of course, treatment was started immediately in that case, no consequences, but this is also something that may happen. So if we wish to conclude, we may say that serology maintains a high value on both screening and diagnostics. But even a specific IgM response will not be sufficient to diagnose a primary infection by Gondii or by Toxoplasma gondii or CMV. The standardization of IgG response is yet to be achieved. Okay, we cannot expect to transfer IgG quantitative results from an assay to the other. There is a likelihood to harmonize the results to bring those to a decent level of agreement, but not definitely to convert. And we have seen that the combination of IgM and IgG results plus IgG avidity allows for the best diagnostic approach. But I would like to reinforce this concept. Serological results, serological testing given by the most accurate assay need to be evaluated in the specific context. Remember what we have just seen. In diagnostic setting, especially in those when you do have the clinical picture, the clinical history, anamnestic and clinical data are for sure of utmost relevance. And that's it for today. Thank you. I will be very happy to hear your questions now.
Thank you, Dr. Galli, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many of your questions as we have time for. Let's get started. Our first question is it possible to distinguish a CEMV IgM response to a primary infection from the IgM response following reactivation?
A good question. Thank you for asking that. Unfortunately, not. There have been some studies in this sense that, well, first of all, the level of IgM antibodies is not predictive. So usually you should expect to have a higher level of CMV IgM in primary infection, but it depends very much on the time for testing, so it may overlap with the ones you will find in a recurrent infection. There were also assays to use Western blotting for IgM in order to distinguish a response linked to an early infection from a later one. And this is still debatable, and for sure it is not something that is used in routine. So unfortunately not, and this is why it is so relevant to run IgG avidity when you have a positive CMV IgM in pregnancy, when the diagnosis of a recent infection is crucial.
All right, thank you. Next question. Which may be the best interpretation in case of discrepant results for rubella IgG at low levels, such as 15 international units per ml by one assay and negative by another assay?
Okay, so the basic question is false positive or false negative, right? Well, it depends on the context. In pregnancy, if you are trying to assess an immune status towards the rubella virus, it is safer if you wish to have this sort of a higher threshold. So assuming that you have this low result by any given assay, as we have seen, this will not guarantee protection because there have been cases of infection or reinfection despite the low levels. So On the safety standpoint, it would be better to have a low reactive score that's negative and propose a further dose of vaccine instead, or at least take the precautions in order not to get infected during pregnancy, instead of labeling that case as a protected person that is not at risk of developing rubella. So this is my interpretation, if you wish, on the clinical side.
Right, thank you. Next question. Are there differences in the CMV IgG avidity thresholds across the different commercial assays, and how do they compare?
Yes, there are differences. All assays have a different way of evaluating avidity, and the range of response for a recent or a not recent infection is not the same. If you wish, from a mathematical standpoint, there is a good correlation across assays, but it is very difficult to translate the avidity result from one assay to another one. So this is for sure of the cases in which you wish to maintain testing by the same assay throughout the course of monitoring. Not because the assays are not accurate, in order to avoid confusion, especially on the side that the people will be receiving the answer, which is maybe the most complicated things to do.
Thank you. Next question. You said that quantitative assays for toxo or rubella IgG are not truly comparable and a qualitative result may be better. Is this process underway already?
Yeah, unfortunately, as we have seen, if you wish to have a real correlation in the pure sense of word across toxo or rubella IgG results, you won't get that. Or at least they will correlate for sure. Again, they're measuring the same entity, but the results will not be transferable. If there would be a chance or a decision to revert or to move to a qualitative result that is positive, negative, it could be better. But there are a few issues there to be solved. First of all, there is still the habit of looking at toxo-IgG level increase over time as a way to diagnose. So if you lose the quantitative aspect, this will not be available anymore. And this may bear some relevance in reactivation. The other point is that the need that I mentioned is more for rubella. And, there have been quite a few meetings on that. I do remember at least a couple of WHO meetings on rubella IgG standardization that ended up with the general conclusion that all parties should agree among themselves, that is, the WHO itself, if you wish, and ISBC, the manufacturers, in order to, first of all, have the assays at least standardized towards the same preparation, which is not yet the case. And second, try and agree on a certain level of positivity that could be deemed as sufficient in order to guarantee that the person is really immune. In that sense, I cannot tell anything specific about the company I'm working for. So at the point that we are here, we are considering that likelihood, but will not be something that Abbott will decide alone. Should be a joint decision that will involve all diagnostic companies and authorities.
Thank you. Next question. Is Abbott considering to have a rubella IgG qualitative assay and not more quantitative?
But again, this is what I just told. It is not Apple's decision or another company decision to do that. There is, let's say, a tendency to move in that direction. If and when an agreement will be reached in that sense, I'm pretty much sure that Apple will follow the flow or participate in the discussion and endorse that likelihood.
All right, thank you. Next question. What is the place for nucleic acid testing in diagnosis of these infections?
Aha, that's another ball game, a third one. Yeah, there is space for toxo and especially for CMV, if we are limiting to the three infections we've dealt with today. CMV for sure. CMV for sure, especially in immune compromised people, there is a huge space. And in that instance, serology will not add much. We have seen at the end that case of a transplant recipient that acquired an acute CMV infection. When you have patients that are severely immune compromised, there is either the need of preemptive treatment or the need, in most severe cases of severe immune compromission, to start antiviral treatment as soon as possible when you do see an increase in CMV DNA levels. That for sure. For toxo, that's a little bit conflicting. And by the way, testing for toxo DNA is not so easy. For CMV, there may be questions on the best matrix to perform testing upon, and the period of doing that. For sure, there is a space for that, as I've told, in immune compromise and even during pregnancy, because there is a direct effect on the viral load in the mother and the transmission to the fetus. So the answer is yes, there is definitely a place and quite a huge one. Let's say that in this instance, serology just sets the ground, so the infection is there, and then the relevant activity on the infection should be for sure ascertained by nucleic acid testing.
All right, thank you. Next question. Is there a clinical value of prodrome versus postdrome in early rubella infections in pregnant population?
That's interesting. Yeah, I don't really have an answer for that. I have no direct experience in the clinical value of prodrome versus postdrome in early rubella infection. The point is that the initial phase, the clinical phase of rubella infection is so vague and so easy to be confounded with our acute viral infection that actually the clinical value of the prodromic or postdromic status, I would say it's at least questionable.
All right, thank you. And we will wrap up with that final question. Thank you, Dr. Galli. Do you have any final comments for our audience?
Guess possibly we have another question also that could be of interest. I see that on the
I see that one
Q&A.
now as well. Yes. There is a study from Picone from 2019 showing very elegantly that low level of rubella IgG are protective. Is that study not convincing enough? You mentioned that low levels should be questioned. Can you comment, please?
I can only repeat what I said. I know the study. This is quite elegant, but it's not conclusive in my view. There are other evidences to the contrary. So once again, we are dealing with something that is very slippery, at least. So low levels by one assay may be higher by another assay, may be negative by a third assay. Once again, we should all agree on which is this low level that will guarantee indeed protection. And just for the sake of it, every kind of result that we have seen or we may see, of course, will bear a level of uncertainty. So we should be very careful in assessing which is the true protective level for rubella IgG, if any, and we should then agree all on that level and how to measure it.
All right. Well, thank you, Dr. Galli. Do you have any final comments for our audience?
But the final comment is thank you again so much for having attended today. I was very pleased to be here with you and very pleased to receive so many meaningful questions. And I'm looking forward for the next opportunity of meeting you all. Thank you.
Well, thank you again, Dr. Galli, for your time today and your important research. We would also like to thank LabRoots and our sponsor, Abbott, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period, will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.